Well, happy Friday, everyone. Thanks for joining us for our, it's Friday, so I always say we like to edutain on Friday here at NMQF. My name is Brandon Garrett, and I work with the National Minority Equality Forum. And today we have a program focusing on data. And, if we're talking about data, we have our one and only very own Courtney Lang. I say very own because Courtney has been with NMQF I think longer than I have. And she has been doing the yeoman's work in the policy space. And I consider myself a policy person, but between Courtney and Gretchen and other folks that we have on the panel today, you're in for a real treat that people that really know and understand public policy in the healthcare space, especially as it applies to uh, the new world order that we're in right now, for lack of a better phrase. But with that, I'm gonna go ahead and maybe that's not the best, but I'll go ahead and turn it over to my law professor, Courtney Lang, to go ahead and lead this discussion.
Thank you so much, Brandon, for your very generous introduction. And thank you to the National Minority Equality Forum, Dr. Gary Puckrin, for providing a platform for today's discussion. We are so glad that you have joined us for this important conversation on data disaggregation and the modernization of Statistical Policy Directive 15, also known as SPD 15. Which determines how race and ethnicity data are collected and reported by federal agencies, and by extension, how communities are seen, how communities are counted, and how communities are resourced. Our work as a part of the Data Equity Coalition has been to protect and preserve the recent updates. I want to introduce our panel briefly, and then we'll turn it over to Gretchen Wartman, who will provide some opening remarks on behalf of the conveners of the Data Equity Coalition. First, Dr. Carla S. Alvarado, Director of Research for the AAMC Center for Health Justice. She works to ensure that the quality of research and application of intersectional frameworks and policy actions reflect in community. Her dissertation was actually to investigate disparities in health outcomes and healthcare utilization. Remarkable presentation at the NMQF Summit, and we're delighted for her to join us again today. Adam Bedwawi serves as the Policy and Research Manager for the National Network for Arab American Communities, and he has been working with congressional and administrative staff on Capitol Hill for advocacy for communities of MENA population, Middle Eastern or North African. He is widely known for the Count MENA In campaign, which was very instrumental in making sure MENA was represented in SPD 15. And last but certainly not least, Karen Howard, Director of Policy and Advocacy for Mental Health America. Priorities and strategies for MHA's key issues, including healthcare, education, criminal justice, are part of her purview, and she works diligently for advocacy on behalf of so many individuals that are underrepresented. Her ability to mobilize grassroots to action is truly unsurpassed. And with that, we are delighted to welcome Gretchen Wartman, who is going to give remarks on behalf of the Data Equity Coalition co-conveners. Gretchen, thank you.
Thank you. And thank you all for joining us. I bring greetings from Dr. Gary Puckrin and the entire National Minority Equality Forum team to this continuation in a series of webinars on this extraordinarily important topic, which essentially is taking steps, being proactive in assuring that all population cohorts are visible in the health services research, delivery, and financing universe. Our topic speaks to shaping the future of healthcare, but I would say, as many of you know, that means that in the moment, in real time, we're shaping the present of health policy and conversations about health policy. So I will, given that we're at 12:05 and we're going to stay on schedule, I'll return this to Courtney Lang. I'll be here to answer any questions you may have, but I also encourage you all who are not actively engaged with the Data Equity Coalition to follow up with Courtney regarding your opportunities for joining us. Thank you.
Thank you so much, Gretchen. We appreciate your leadership and the leadership of Blue Cross Blue Shield Association, to help bring the Data Equity Coalition to light. Your joint commitment has made a difference in the lives of so many. Today's discussion will explore the implications of SPD 15 across sectors and will focus on real-world case studies. I want to make a technical correction, Adam Bedowi. And Adam, if I pronounced the last name incorrect, please jump in.
Badawi. Thank you, though, for okay. Trying. I appreciate
Absolutely, absolutely. I'm so sorry about that. Now, Adam and Carla are going to be our sort of opening clarifiers of what data disaggregation and intersectionality mean. And so for the both of you, I wanted to turn this question: why is data disaggregation such a critical priority right now? And why does preserving and protecting SPD 15 matter in this moment, in time, in history, more than ever as a priority for policymakers and communities at large? So Carla, why don't we open with you and help to level set?
Sure. In terms of intersectionality, just a quick kind of crash course. Social stratification happens across societies in the world, and that social stratification comes with social categories, which render positions of advantage and disadvantage. And if you think of any social category or identity that you can think of, you automatically dichotomize those into socially advantaged and socially disadvantaged groups. It can be gender, male, female, it comes to mind, which one's disadvantaged, white or people of color in case of race and ethnicity. And in terms of wealth, the poor and the affluent, right? So in these positions, there are these create certain locations in the social context. And these locations speak to the tangible and intangible resources that we have to create and maintain health. And so in terms of the tangible, you have wealth, property, and the intangible is the power and prestige. And these come together to then create our experiences through the world. Jumping into intersectionality, we know that these positions are not fixed. These positions are contingent on social context. And so the power dynamic is fluid. In terms of intersectionality as we know it now, as we invoke it, the basic tenets are: we inhabit multiple simultaneous positions of advantage and disadvantage in the different social categorizations that we inhabit. And so they're multiple, simultaneous, and mutually constitutive. They create one another. No one lives a single issued life. No one lives from the life course perspective. Your identities take saliency in different contexts. And the last thing I'll leave us with in terms of intersectionality is that we have the ability to change the social context. And that is where we talk about health outcomes, health inequities. Mm-hmm. One of the things that intersectionality does warn us about is that macro categorizations create invisible minorities. So inevitably, when you start categorizing people, you will leave someone out. And to segue into the data disaggregation component that Adam will talk to us about, these macro categorizations that leave invisible minorities, that leave invisible issues in certain communities, need data disaggregation so that we can unmask barriers and identify levers of action to address these. So with that, I'll hand it to Adam. Thank you.
Thank you.
Yeah, thank you, Carla. And thanks everyone for joining today. I actually wanted to start with the second question you posed. Why is it so important to protect SPD 15, Statistical Policy Directive 15 in this moment? And I think it goes back to the origins of the policy itself. It's rooted in the civil rights movement, right? You pass all these pieces of legislation that set equity, equal opportunity as a goal, as standard bearing, as a kind of a load bearing pillar of the country and its future. And then you set up this policy to standardize the way that we're actually going to assess how well we're doing moving forward. And I think right now what you notice is, we're 60 years after this pivotal moment. And I think there's a broad recognition across the country, an increasingly diverse country, that we haven't necessarily made good on those promises. There's still a lot of work to be done. Obviously, we've made tremendous strides from where we started, but there's a lot more to do. And so what the Biden administration did in 2024 was, I think, take a dramatic step in a positive direction by, number one, requiring data on Middle Eastern and North African populations to be counted separately from the white category, but then also, most importantly, as you alluded to in the first question, requiring that agencies, when they're collecting data on race and ethnicity, do so at the most detailed level. And what that will do is allow for researchers, policymakers, advocates to understand not just the way that very broadly understood communities differ from one another and how well we're doing with respect to those communities, but also whether we're accounting for cultural, racial, ethnic, linguistic difference within those populations. And then to design more tailored approaches to address the needs of those communities as they are, as Carla mentioned, in their specific context where they actually live, where they work, where they seek healthcare and so forth. Now, of course, there's a lot of still work to be done to improve on the way that we've been doing this for 60 years now. I think that for us, it's important now that we don't just make this a technical, data-driven enterprise, but that we connect the quantitative with the qualitative, that we use what we are able to observe in data at this very detailed level to actually get closer to where people live, to speak to the organizations that really serve them and understand those contexts better, because I think there's a lot more work we can do to better address those disparities and ultimately just improve the quality of life and quality of service. I think one important thing I want to mention as well is by separating the MENA population from the white population, we're not just going to be able to better serve MENA populations by understanding their outcomes and conditions and the factors that ultimately contribute to those outcomes, but also we're going to improve the way that we can understand disparities between all populations, because you're essentially producing a more accurate read. I don't think I need to make a strong case. I think everyone will understand me when I say that the people who hail from the Middle East and North Africa have a very different lived experience than people who hail from Europe, historically in this country and just in general. So, I don't say this to say, one way or the other, whether it's one experience is better. It's just more accurate to understand it that way. And then you can understand how all of us differ. And then as well, the different, the factors and conditions that shape outcomes for all of us. There's a very good chance that language, linguistic barriers, sort of genetic predispositions, impact us in similar ways. I think it's important for us to look at the very granular level, but then also kind of extrapolate back up and see, okay, what are the things that impact all of us, and that we can design tailored approaches to meet communities where they're at. But we have to understand ultimately the things that the experiences that we share. I think this is an opportunity, like the detailed data thing, I think kind of scares some people. It's like we're going to really get into the nitty-gritty and carve all of our communities up into these subgroups and subgroups of subgroups. But I think I would also caution us from doing that. It's important to look at that detail level so that you can get back up to okay, what are the things that impact all of us? And it doesn't have to be just one thing, right? But there's a very, very good chance you'll be able to find 5 or 6 or 7 things per issue that you can set up as initiatives and then address those. So again, there's a lot of promise and potential, but of course we need to number one, just protect what has already been done, protect statistical officials who've been laid off, who were doing this work, and then of course improve upon the way that we've been doing this disparities analysis and designing programs to address those disparities moving forward.
Thank you so much. I appreciate the focus on individual identity, the social context, and particularly honoring lived experience. And in speaking of lived experience, and Karen, I'm going to transition over to you here because I think it's so important to make sure that the audience is clear that the Office of Management and Budget updated Statistical Policy Directive 15 last March, first time in 30 years. And those were the minimum standards, friends, the minimum standards. So with the Data Equity Coalition, we recognize those are the minimum, but we ask for so much more because we recognize the importance of language, as was just discussed, and identity on all platforms, sexual orientation, gender, etc. So with race and ethnicity being the focal point of SPD 15 and lived experience, Karen, I wanted you to maybe offer the audience some perspective on a use case that was followed and focused upon in the issue brief that was released last year, and just help to ensure like how underrepresented populations are protected within healthcare policy and delivery when it comes to ensuring intersectional data is preserved.
Sure. Thank you so much, Courtney, and wonderful to be here with everyone. I'm the Senior Director of Policy and Advocacy at Mental Health America, and we're a consumer advocacy organization based on helping to ensure that patient voice and personal experience is really a part of conversations at both the policy level and in any treatment decision-making. The shared decision-making and ensuring the patient feels empowered is a key principle in our work. So, in our issue brief that we worked on in conjunction with the Data Equity Coalition on youth mental health, we really focused on a part of identity that has not always been discussed, which is disability status. There are several agencies that do collect some type of form of disability status in their surveys. However, there is no federal standard for what disability status data collection should look like. So, the census has a different kind of data point than the Department of Education to identify youth with kind of impairment or disability, and that they have a different definition at NIH and other agencies. But what we can find and what we do know is there are disparities between those with disabilities and those without. Those disparities come into play as young as childhood and can be seen in patient or healthcare outcomes. But while there is no federal standard for a definition of kind of disability status and all that is included in that, there are several key pieces of legislation that do protect people with disabilities and do require some form of support or accommodation for them. In the issue brief, we highlight the Rehabilitation Act of 1973, especially Section 5415. We also highlight the Americans with Disabilities Act of 1990. We also highlight the Affordable Care Act, especially we're all probably familiar since this was during our careers and tenures, the Section 1557, which in light of the recent Supreme Court case, Skermeti, we see kind of some retractions or some steps back that have been taken by the administration in ensuring that certain populations are free from discrimination. So there's an ideal that we have, obviously, and COVID really was a time where disparities became much more, I think, visible to general population in who had access and who did not have access to care and services and information that was trustworthy. And those with disabilities certainly had poorer outcomes before COVID, but I think with the reflection and assessment of care during COVID, I think it was very well understood across all industries that we needed to do more in reach into specific communities, including families of people with disabilities, so that young people and their parents had the support that they needed at the time. For there's been a youth mental health crisis over the last decade or more. However, if you break it down by race, you see that access and care and services for white youth were improving, while access, care, and services for Black youth were not improving, and in fact, declining and getting worse. And so data disaggregation by race, ethnicity, language showed us that. But if you looked at the overall numbers of how youth were doing, you would think, oh, things are improving for young people. There are several reasons and contributors to why that is. Of course, access to care, who's spending time where socially, and psychosocial supports that are in place to help young people and families. But if you go further into that data and look at which families of young people had a disability in the family and those who didn't, there was even more of a story to be told around being able to access care. And when a person or when a child or their parent had a disability, almost 50% of the time they had more trouble with finding a mental health clinician to help them with any mental distress that they were experiencing at the time. And that was found by a national survey that HHS put out that I'm happy to share the link to. But we highlight that more in the brief. We really know that when we do in-reach into communities versus expecting individuals and families to come to a system, there are much better outcomes for those who have been marginalized. And we see some increasing marginalization over time. In this time that we're in, we know this is just a time period and things will shift in the future. But as federal agencies, state and local agencies are seeing funding cuts and other policies that intend to chill or reduce reliance on public services, it's really important that data collection is standard so that we can surveil what's happening, track and monitor so that systems can be responsive. And while some systems do a better job of being responsive to consumer input and input from those being served, there's always improvements that can be made. And we see, for instance, as a specific example I want to give is that currently, last year states had been given additional funding through the appropriations process from SAMHSA to start up these CCBHCs, that is an acronym for Certified Community Behavioral Health Clinics, which is an integrated care model that allows families to come in, receive primary care at the same time as they're receiving mental health services. That is a key model that helps those who have different cultural backgrounds or familiarity and comfortability with mental health to receive the services they need in a safe place that they're comfortable going to, especially in rural communities where you don't want to be the one that's seen as, oh, I have to go to that particular parking lot, park my car, and be seen outside of the mental health clinic because that means something is wrong with you. As states were deciding how to spend these millions of dollars for setting up CCBHCs, if they had data on where the most vulnerable populations were and who needed to be served most and prioritize setting up those clinics in those communities, we would see those who have been most marginalized really come into the averages and into general population with additional supports that's needed. So
that's a great example.
That's an example of how data around disability status, race, ethnicity, language, and other cultural and identity factors can be used to ensure that federal resources and policy support meeting the needs of individuals where they're needed most.
I appreciate that. There are 2 points that I really want to highlight for the audience. One, your specific example about rural communities, and I want to invite our other panelists to join in this part of the conversation and discussion, because I know that Dr. Alvarado also has perspective on rural communities in terms of what's happening in Texas, and Adam as well, because and Gretchen for all of the work that we have done within the broader advocacy. So I want to lean into that around the geography a little bit, and how geography matters when it comes to data disaggregation. And say we're collecting data, as Karen just highlighted, right? But then it's not disaggregated, it's not acted upon. And I thought the other point that you made, Karen, is that if you look at the data holistically, it looks like we're doing great. But then when we cut it by race and ethnicity, Black and brown communities were being harmed, right? So please, Dr. Alvarado, Adam, Gretchen, the question that I want to pose are, what are the risks? What are the risks for communities if disaggregated data is collected and we don't act on it?
The risk is not being heard. The risk is not thriving. The risk is suffering. The risk is limiting our potential, economic well-being. It really involves all of it. And bringing it back to my home institution, the AAMC, they've had the SPD, in a way, the integral points of the SPD 15. They've implemented those ahead of the time, if you will. There is a physician data initiative that has recognized that the MENA population has been left out, for example, and that it contemplates issues that are, germane to each of the communities. And so this physician data initiative standardizes the way for categorizing, reporting, and sharing sociodemographic data. And that's of importance because we need a representative health workforce to tend to the health ailments of the communities, whether they are in rural areas, whether they are in urban areas. And then having a representative workforce then means that the people who show up at the hospitals, at the clinics, at the FQHCs are seen, are heard, and are understood. So in terms of even language, this data initiative also brought in language in recognition that that is one of the biggest barriers to access to care, and then for the outcomes that emanate from the healthcare interaction.
Thank you, Carla. Excuse me, Adam, please.
Yeah, so this kind of goes back to the point you were making about the importance of this data being disaggregated, but also us taking kind of, as you said, an intersectional lens in considering other factors that contribute to outcomes. Because, let's take language, for instance. Arabic it's not the only language, of course, spoken in the MENA region, but a significant number of MENA populations are Arab, speak Arabic, but Arabic itself is spoken differently, on a regional basis in the MENA region, right? So you have Levantine Arabs, and this language, of course, there's a similar basis. Everyone kind of draws upon what they call modern standard Arabic, but historically, and due to kind of cultural factors and other historical contingencies, the language has sort of diverged on this regional basis. And then those people come here, and that dynamism of that permitted Arabic to be spoken differently on a regional basis doesn't just stop at the border, right? You bring it with you, and you develop a different kind of regional touch, let's say, to the way individuals interact in Dearborn, Michigan, or Anaheim, California, and so forth. So on one hand, just understanding where people are actually located, and of course where they come from. So now you're talking about country of origin data, you're talking about language data, and you're talking about regional data or geographic distribution. And then you're also looping in, are there significant numbers of MENA populations who also speak that language where they were in that region that you're looking at in the United States. Because then that can also correlate with, okay, did those people there have community organizations that can serve as an intermediary, connecting them to services, empowering or supporting them in other ways. And then of course without that you have communities who may continue to be underserved, may continue to suffer from informational or educational barriers to effective uptake of services. And so for us, when we look at the region-specific data, for us, we want to look at kind of what I had alluded to. Like, do they exist in a context where they have support available to them? There may be people in the workforce who can also improve the quality of service, provide more culturally or linguistically tailored services. For us, the National Network for Arab American Communities, the organization I represent, is a coalition of 36 Arab organizations in 13 different states. And so you have their organizations in, like I mentioned, Dearborn, where there's the largest Arab population outside of the Arab world. But then you also have communities who are, there's still nice, strong pockets of the communities, but they are a minority in the broader scheme of things. Let's say in Nashville, Tennessee. And that's one of our organizations that serves the Coptic Egyptian community there. Yeah. And so again, if you're looking at these communities on the basis of like, okay, are they MENA? You miss a lot of important nuance in understanding and kind of contextualizing the outcomes that you're looking at.
And I like the reference, Adam, that you just made about you'll miss something if you look in isolation as just MENA, right? It really speaks to the intersectionality. And I think that's a point that you all have emphasized beautifully, Dr. Alvarado, Karen. I wanted to make sure that Gretchen could also jump in here because the National Minority Quality Forum has done a beautiful job for over 2 decades, really emphasizing the importance and the priority of data collection standards as it relates to patient outcomes. And we have some use cases that NMQF has been carrying forward well beyond and before this conversation really even hit the mainstream. And so, Gretchen, I was just going to allow you to just kind of jump in and give some perspective on the historical work that NMQF has provided to this conversation, to this space as it relates to data disaggregation and the impact on patient outcomes that your organization has been championing for so much time.
Thank you, Courtney. Another 20-question, single question. You're right.
Kind of one question, but right. Multi-parts.
Right. I would say that, and my thoughts were initially triggered by Dr. Alvarado, but by Adam's comments as well, actually all comments. The National Minority Quality Forum exists not because we only wanted to focus on populations that were narrowly defined as minority at that time, but to remind the system that these population cohorts are here as well, and our information, often without our knowledge, is included in the denominator of analyses of policy needs, of legislative needs, but also in the science. And so as we have these conversations moving forward, I think I encourage us to, yes, continue to focus on populations who I would say almost in thoughtless in the sense that it's assumed that some of us will be marginalized because of the history of this country. But what we are facing, and an opportunity that's presented here, is that populations who did not think of themselves as minoritized or marginalized are beginning to experience the anxieties associated with being invisible, with being devalued in the way policy is designed. So the National Minority Quality Forum has always recognized that in order to move racial and ethnic populations forward, you have to collect data on everyone. Because, as one of our speakers said, it all occurs within a context. And what we have an ability to do now, and I think an imperative to do now, is to assure that that context is not just regional or community, but is actually global. Because our the basis of the information and the science that drives us into a future that by default includes all of us is a global conversation. So I'm not sure if I've answered sort of
Yes.
all of the different aspects of Courtney's question, but I would say maybe that the opportunity here, once again, is not just the imperative for those of us who are traditionally defined as minority or minoritized, but given the experience that we're all having at this point, the anxiety, it helps create an imperative for all to support increased precision in the data that we collect, regardless of your political leanings, regardless of what you perceive to be or you think to be the solution to the challenge. You need data to inform that. And that's where the Data Equity Coalition and others who assign this as a priority are available to help move our society forward. Thank you.
Thank you so much. No, Gretchen, that was really important to kind of contextualize the work of the Data Equity Coalition and the historical importance that NMQF has played into this dialogue. I'm going to ask the audience to place their questions in the Q&A function on your Zoom platform, in the Q&A function. That would be extraordinarily helpful. I do have a question that kind of mirrors one that actually was submitted in. And Karen, I'm going to start with you because it really speaks to your area in terms of what policy recommendations would you prioritize right now to enhance data equity at the local, state level, federal level. And I will help to address one of the questions that came in the chat. If you could just share a little bit of insight on how like state Medicaid entities should be thinking about SPD 15, given where we are today, just kind of politically. And Mental Health America just had a fabulous webinar. You should put the link in the chat as well, because I think it speaks to this broader conversation, really synthesizing the Medicaid stress that we feel in healthcare with the importance of data equity and data disaggregation. So Karen, floor is yours.
Thank you. I'm really happy this question came in the chat because I just yesterday had a conversation with the National Association of Medicaid Directors about some of the challenges that they're facing. So I would say there are two kind of policy recommendations that we can be advocating for at the state level. Both in the context of this HR 1, One Big Beautiful Bill Act, which significantly reduces Medicaid funding by up to $800 billion, and both outside of that too. First, that bill really, most of its provisions don't take effect until 2027. However, state legislatures will be required to make some very challenging decisions about their budgets in the upcoming session starting in January of 2026. And so first of all, Medicaid data sets are some of the largest that we have. Researchers spend, days, weeks, months really going through some of the data. And there's a particular TMSIS system that collects substance use data, outcomes, services. And so when we're talking about ensuring that that data is comprehensive, we want to collect more than just substance use specific data. We want to collect the co-occurring conditions, including mental health disorders. And we also want the identity information, race, ethnicity, language, disability status, and other. And we want all of that really in one place that allows researchers to comb through, analyze, and really help inform states about what models are really working across the board and cutting through disparities that might exist in inpatient outcomes.
Super helpful.
One of the really important things that state Medicaid agencies are trying to figure out right now is how they can come into the 21st century with their technology. And so there is a lot of advocacy and I think persuasion that needs to be done in ensuring that Medicaid agencies or that governors are setting aside funding in their budgets for health IT experts in-house, in the way that you would bring an in-house counsel who can help with ensuring the agency health IT is interoperable, it's able to protect consumer data, as we're seeing more infiltration from, the wrong types of hackers and things like that. There are some systems, the COBOT systems that, were developed in the 70s and the 80s. And, some states have gone through kind of a health IT transformation of their Medicaid programs, but one of the provisions in the Big Bill Act is HR 1, is that state agencies are going to now have to cross-reference data that they have on file for work history or work kind of engagement, and whether a person is receiving food assistance. And they need to be able to basically have data systems talk to each other around work, nutrition assistance, and their healthcare services that an individual is engaging in. And all of those systems have different, setups. And so ensuring that there's some ability for those systems to talk to each other is an important part of ensuring that health outcomes are less disparate, because without those data systems talking to each other, you're really, walking in the dark and trying to figure out, it takes much longer to figure out who will be served and who is not being served. There's also some exemptions for who's required to work or contribute to cost sharing. And so, state Medicaid agencies really need to be investing into health IT and data security in that sense that really facilitates that so that people aren't losing their coverage unnecessarily.
Dr. Alvarado, and then panelists, I want to make sure that we turn to some of the Q&A questions that have been submitted. So Dr. Alvarado, I'm going to let you respond, piggyback off of what Karen just said, and then maybe just give a nod to one of the policy recommendations that AAMC Center for Health Justice has pushed forward in this regard as it relates to federal, state, and local data policy. Thank you.
Well, to answer your last question first, we were supportive of the SPD 15 in that it combined the race and ethnicity question because people were more receptive and were more likely to answer that question. And again, the integration of MENA in those categories, along with assessing language. But like I shared that position initiative, it has more information there. But I was smiling while you were speaking, Karen, because it talks about you're talking about the need to integrate data systems and have it be interoperable, which, you know, there were billions of dollars infused into that system about 10, 15 years ago. And it's just either ironic or regrettable that the impetus for that happening now is more for possibly denying or tracking people rather than it is for, you know, the health information exchange for the sake of the well-being and having an integrated life course kind of view into patients and that type of information. But to your point about Medicaid needing to, at the state level, needing to have health IT systems as well and in-house IT specialists, I think industry is very important here because those states are really using vendors, and those vendors then are the ones that hold and operationalize, if you will, what has been set forth in SPD 15. And so a lot of the vendors that make the money off of selling to insurance companies, they also sell to the state. They need to update their products to be compliant or to align with SPD 15 in the absence of such let's say, formal request for changing and updating the data collection and the fields that need to be collected. The industry itself has customary policy power and soft power in the sense that wherever they go, whatever they do to their products gets integrated into state government, local government, and federal government. And so we need to also look at industry as a lever that can push what is being supported in SPD 15.
Thank you so much. We have a question in the chat, which is a very important question. Adam, I'm going to have you answer this first question because I want to make sure that it's very clear to the audience. What is the current status of SPD 15 in terms of what's happening as we see so much dismantling occurring on the policy and regulatory front? What's the status of SPD 15, Adam? Can you give us the mini response? Yes.
Yeah, so obviously the revision was issued March of 2024. And agencies across the federal government were given until September of 2025, September 20, I believe September 29, to issue their action plans for how they are going to actually implement the revision. And then all agencies were given essentially 5 years to actually, bring their collections into compliance with the revisions. So September 28, 2025 for those action plans. This is where we'll see a lot of what they're envisioning. All the stuff that we're mentioning here, we'll see the extent to which it's actually incorporated. And then March of 2029 is when, God willing, we have, we actually see what was issued, brought into being. Right. But in terms of, so that's like kind of formally what was, issued. And I know people are very familiar with that, but internally, there's a lot of, there's a big mess right now where a lot of the officials who were working on the implementation process have either been laid off or are doing that work, but kind of in secret because they're concerned about the current administration viewing, what they're doing as, essentially a departure from their priorities or what they would otherwise want. So we're seeing kind of a chilling effect in a way on these action plans, on the actual implementation. And then also, of course, you need funding to do a lot of the work. And if you don't think that you're going to have funding, then your plans may be a little bit less ambitious than they otherwise would be. So we're seeing kind of a direct impact on a lot of the political machinations, let's call them, that we're observing. Like this direct impact on just, are people even in those offices anymore that are, in those evaluation offices, in those statistical agencies. And then, of course, you'll see kind of a cascading effect on how ambitious are these plans and whether we actually meet that 5-year deadline for, implementation. And then, of course, that has cascading effects at the state and local levels where everyone's kind of in a holding pattern waiting to see, well, is this actually a priority? Do we have to be in compliance? Where's the enforcement going to come from? So I wanted to keep it brief. So obviously there's a lot to get into there, but that's kind of the nitty gritty.
No, that's super helpful, right? So I'll just reiterate, Adam, to your point, there has yet to be a rescission or a revision of SPD 15. It has not been revised. There has not been a rescission. Federal agencies, many of them, have actually already met compliance. Many of them did that at the end of 24 because there was an anticipation of the update to SPD 15. And so independently, a lot of federal agencies actually have met the agency requirement. We are very concerned about the enforcement. And so that is something that we will continue to monitor. I do encourage going on to the Data Equity Coalition.com website, because we'll continue to post updates there that are accurate and making sure that we're communicating all of the information out to the public at large.
And if I could, sorry, you reminded me,
Yeah.
you offered some very helpful, additions to things I neglected. But one thing you reminded me as well is, it's been mentioned here that one of the great things about the revision in March of 2024 was that the requirement for the data collected to be at the detailed level. And that's something that we're seeing not necessarily being honored in the implementation, even where people have, let's say, added the MENA category, but there's not this impetus or follow through on the detailed level data. And so that's a huge threat to everything we talked about.
Exactly. Really important point. Gretchen, a question that came into the chat is something that we've talked about at the Data Equity Coalition convenings, and it's how do we expect anti-DEI work to intersect or potentially undermine SPD 15 in the commitment to data equity. And so thought maybe you could just offer a brief remark there. Very brief.
Yes, okay. This is brief. And it follows on Adam's comments as well. I think we are captives. I know that we are captives of our statutes and our norms. And what we're experiencing is what occurs when the language of the statute does not reflect what we've been led to believe are reasonable expectations based upon regulations, okay, or rules. And so I would like to think that where we are right now is a worst case scenario, but we all know based upon history that things can get worse. Okay. And so even though we don't necessarily, we may not have sort of alignment in Congress or in state legislatures that would be ideal, we have to continue to work at the with elected officials to create a statutory foundation for what we're speaking to here and what we know is happening in other states as well. And I would say that continuing also to work to assure through the options that we still have to sort of enhance the focus on the precision data, not only regarding counting of different population cohorts, but being able to link it to, and I think it gets to Karen's issues, outcomes data. We have the ability to monitor what's happening and interpret it in a way that can trigger action. And so I'm going to stop by saying I encourage us to continue to find ways to work together to assure that our societal foundation is responsive to the health and well-being of all of us who are here.
Thank you so much. I want to do two housekeeping matters. There's a question that was placed in the chat that's actually speaking to the weaponization of data that I was going to ask Dr. Alvarado and Karen, because it references both Medicaid as well as some issues related to immigration. If you all wouldn't mind responding to that question via typing just a response or a link in the chat. It's in the Q&A aspect. If you all could respond to that Q&A aspect in the chat, that would be extraordinarily helpful. I wanted to make sure that we addressed all of the questions that were put forth from the audience. And I want to take this time to give each panelist a final thought to leave the audience with that they can use as a takeaway, that even if the federal government remains silent on enforcement of SPD 15, can you give them one action that they can take to help with supporting implementation, protecting, preserving those minimum standards that were put forth? And so, Karen, I'm going to start with you. You're on the mute. If you
Oh
could just
man,
unmute.
Courtney, I'm so sorry. I was responding
okay.
to the question in the chat. So
Oh, okay,
I
okay.
missed you.
Oh, okay. That's okay. That's okay.
Can you repeat the
Of
question?
course, of course, of course. No, I was asking that even if the federal government remains silent on the enforcement of SPD 15, is there one concrete action that you believe organizations can take to help to advance implementation of the minimum standards for SPD 15?
Well, as all of us are in the advocacy space, I would say just continuing to educate folks. I think there are, long-term civil servants that haven't been RIFed that, are doing their due diligence to try to hold the fort down, and, continuing conversations with them, and educating the community and our folks on the ground about the importance of SPD 15, how it came about, and
Yes.
that there's, kind of a reversal of a ton of policies, but that, there is a reason to still have trust in certain agencies and those who are those leaders and agencies who are carrying out what they're supposed to be doing.
Yes.
And so I would say that just educating is still important to do.
Always powerful, always powerful. Dr. Alvarado, 60 seconds. Thank you.
Just to reiterate what was mentioned before, that we don't really need this enforcement to begin implementing, right? You have it in front of you, you know what it requires. I would say that even the organizations that do interface with government entities, that they can start doing it as well when collecting information about the service they render to the different communities. So community-based organizations can start collecting this data, or rather they already collected, to abide by SPD 15, the specifications there, and to really talk to their legal team when it comes to how do we manage the data we have now.
Yeah.
And it'll be the same applicability to the SPD 15 requirements. And so just brush up with your legal team about it and how you protect data, and change those categories in those forms for industry. This will come, and it will be almost an expectation of the people who buy your products to operationalize SPD 15 when it comes to data collection and everything and the legalities that come with that. So.
Great point. Education, focus on the implementation, be in control of what you can do. Adam, 60 seconds, 30 seconds, actually.
Well, when I think about SPD 15, I think about it as a tool to use in the production of information that can be used in one or another way, and we're hoping that it's used in a good way. And when I think about the production process, I think about how the data is collected, how it's presented, and how it's ultimately used. And so I would encourage people to consider ways that they can plug into each of these three, parts of the process, and namely how they can ensure that communities and community organizations are included at those stages. Because if people don't trust the person collecting the data, they may not even fill it out, or if they do, they may not provide information that's accurate, out of fear of retribution or it being used against them in some way, and that undermines the entire edifice. And to Gretchen's point about, and then of course, I think the most important part of this is ultimately the utilization of the data, and namely that it's used to improve quality of life, to redesign programs, to better serve what we're able to observe in the data. And to Gretchen's point about building this legislative foundation or basis for a lot of what we're seeing, I wanted to just briefly touch on a bill that we have introduced in the last 2 sessions, our organization, but then also that we're reintroducing this session. I'm going to just put in the chat
the link
to it, and then
Perfect.
also a link to a form where if your organization can endorse, you can feel free to do so at this link here. And I
Perfect.
will cut it here because I know I went way over. Apologies.
Thank
So
you.
one of
Yes,
those links
place
is
the link in
to
the chat. Okay,
Yeah.
perfect. And Gretchen, please.
So, thank you. I'll say yes to everything that was said. I'll leave it with mobilize and engage. And please contact the National Minority Equality Forum or Ms. Lang, and we'd be pleased to have conversations with you regarding how we can link our resources and our commitment to this issue. Thank you.
Thank you. Well, on behalf of the Data Equity Coalition, I want to thank each of the panelists here today, Karen Howard, Mental Health America, Dr. Carla Alvarado with the AAMC Center for Health Justice, and Adam Bedawi from NAC. Did I get it right? Thank you. And Gretchen Wartman. And I just want to say, friends, that today's conversation is part of a broader effort that we are working on to continue to democratize data governance, center lived experience around these use case examples, and to ensure that equity is built into the systems that shape our lives. Being a part of this collective dialogue is a part of a broader movement around data and justice. This is a justice issue fundamentally. We are still working on all of the issues that were presented here today. Please join us, dataequitycoalition.com. Deep gratitude to each of you for all the work that you do each and every day. And thank you to the National Minority Equality Forum for continuing to empower conversations such as these. Thank you so much.
Thank you.